A 29-year-old woman currently in her second trimester presented for a routine mid-trimester anomaly scan. Her pregnancy so far has been uneventful with no history of fever, bleeding, trauma, or infections. The dating scan ultrasound was reportedly normal. There is no known family history of congenital anomalies and genetic screening was not performed earlier. On ultrasound, we saw a single live intrauterine fetus with cephalic presentation. Fetal heart rate was normal, 142 beats per minute. A midline interior abdominal wall defect was identified, located just inferior to the umbilical cord insertion. Herniated bowel loops are visualized, contained within a thin echogenic membrane. Importantly, liver is not herniated and remains within the fetal abdomen. Findings are consistent with omphalocele. Moderate amount of free fluid was noted within the fetal abdomen. This was suggestive of non-immune fetal ascites. Bilateral clubfoot was identified. No limb shortening or bony abnormalities was noted. Amniotic fluid index was within normal range with no evidence of oligohydramnios or polyhydramnios. Other structures including cranium, spine, and kidneys appeared structurally normal. No intracranial abnormalities or spinal defects were noted. The provisional diagnosis in this case was omphalocele of bowel loops only, fetal ascites, and bilateral clubfoot. Differential diagnosis will include trisomy 13 or 18, commonly associated with omphalocele and limb anomalies. Differential diagnoses include trisomy 13 or 18, which is commonly associated with omphalocele and limb anomalies. Syndromic association included musculoskeletal or genetic syndromes. Recommended for further workup was amniocentesis for karyotyping and chromosomal microarray analysis. Tox screening if clinically indicated. Fetal echocardiography to rule out associated cardiac anomalies. The management plan will include parental counseling. Parents should be informed about the diagnosis of isolated omphalocele with ascites and clubfoot. Discuss the need for genetic testing and possible syndromic associations. Emphasize variable prognosis depending on associated anomalies and genetic results. The management options will include await results of amniocentesis to guide further decisions. If genetic anomaly is confirmed, detailed counseling regarding prognosis and options, including possible termination. If pregnancy continues, serial ultrasound monitoring should be done. Plan for tertiary care delivery with neonatal surgical support. Postnatal outlook includes surgical correction possibly in early neonatal period. Clubfoot is treatable postnatally with casting or minor procedures. Prognosis depends highly on chromosomal testing results and associated anomalies. The conclusion in this case is it highlights a fetal anterior abdominal wall defect, which is omphalocele with moderate ascites and bilateral clubfoot without limb shortening or liver herniation. Timely diagnosis, genetic evaluation, and multidisciplinary care planning are essential for guiding prognosis and parental decisions. If you like this case, remember to like, subscribe, and share this video. Thank you.